So once again, welcome to Medical MCQ for all. Right, this is what we provide. Right, in our this medical MCQ for those new students, they get little bit idea that okay, what exactly we are doing here. Right, so we are going to guide you about the everything. This all the questions. Uh, we are going to provide you 1000 MCQ books. So it is recently updated 1000 MCQ book. We have ebook, we have online subscription and live coaching. What we are doing every day, I mean by the various expert. I will introduce you soon. We have WhatsApp subscription, we have Oman Viva subscription as well as coaching, which is not provided anywhere in the world. Believe me. So we are specialized in Oman Viva coachings as well. Along with the subscription, data flow services is done from Dubai. Dr. Anjali is already in the class. She joined from Dubai. So anyone wants to do the data flow exam booking, transfer of the license from DHA to MOH, whatever the other things, contact Dr. Anjali. Dr. Anjali is here, so she will speak little bit at the end of the lecture. Short package is a money get back guarantee package. Means what? I mean somebody's second attempt or third attempt, and they are little afraid what happens if third attempt if I gonna fail. Right. So in this attempt, right, you can go for short. You can inquire with me or Pallavi or our team. And those who did not downloaded our mobile application on Android and iPhone, I must recommend and request you to do the download the mobile application on Android and iPhone as well. So it's gonna be great, right? So this is what the thing is. This is myself, Dr. Munjal. I am primarily trained in hematology, oncology, and bone marrow transplant, practicing almost for more than 20 years, exclusively in hematology and oncology. And I mean, more than 10 years of good experience in coaching and teaching. And I'm founder and CEO of the Medical MCQ for All as well. Dr. Aarti is our consultant pediatrician, gold medalist. She is a brilliant lady delivering the everyday exclusive pediatric class. Dr. Maddie based at Oman, and she is an internal medicine and emergency physician. She is a wonderful speaker. So she is delivering all this internal medicine, ECG, cardiology, and all lectures. The good news is that Dr. Shikha, she is, I mean, in my team for more than a year, and now she shifted recently to Dubai, right? She joined in Aster Hospital, so she will be now delivering the lecture from Dubai. She's already delivering the lectures from India. Now she shifted last week to Dubai as a gynecologist in Aster. So she is also one of the expert panelists doing the coaching on day-to-day basis. Dr. Ankit is a gastroenterologist and he's a DM. He's a super specialist guy. He's taking nice lectures on gastroenterology and GI surgeries and all. Dr. Meghna is also in our team. Dr. Pallavi is also, many people knows Pallavi. She is in our support manager. Our contact number. This is recently updated book, right, which is available in Dubai also. So you can contact Dr. Anjali for availability of book in Dubai. Couple of two things I need to announce before going to the lecture. Combo offer is a coaching mega offer, 40 hours coaching. It used to be 500 USD earlier, now it's 250, right? So almost half the cost. And recently we are, somebody wants to subscribe, enter coaching 50 is our promo code. So you get discount 50% flat on the coaching modules as well. And last but not the least, Dr. Anjali, as I told you, is the head of data flow. Her numbers, mobile and WhatsApp and everything. Myself, Pallavi. So keep in touch with Pallavi. And last things, recently we updated excellent new mock test module on our website. So those who are using the website, right, they can give the mock test, they can monitor their result, they can monitor their progress of mock test. And one another module we are launching day after tomorrow is that I can organize one mock test. So anybody from any part of the world can give the mock test in 3 or 4 days. The only condition is that you can't leave the test and half the way. You need to finish and submit the result immediately. So exactly you get the result like the way you are getting in DHA, HAD, MOH or OMSB. So this new mock test has already been done, right? So I can design the mock test. I can give the bifurcation that gynec is 20%, pedia 20%, surgery 20%, legal ethics, emergency. So this is a compilation exactly how you gonna see in the exam. The same mock test will be designed from tomorrow onwards. So you can see your progress, even I can see your progress. So I can even advise you as well It is like more or less assisted artificial intelligence based mock test we are creating. So computer will give you the advice that what you would like to do more exercise in which department, which subject, so you can improve the score. So that would be available. So probably by tomorrow or day after, I will announce once it is ready online. Sorry, right? So this is what the thing is, and two more course we are designing. I probably planning to come to Dubai next month, mid August or end of the August, just to launch one new program called as the EMRI, Emirate Medical Residency Entrance Exam. So those who are MBBS, post MBBS, right, and wants to do the post graduation in UAE, you need to give the EMRI. Shortly, we are making one webinar on EMRI with Dr. Afrin. So probably by next week or so, and we are also shortly launching the new course for dental uh, specialty from medical. So that's all. Let's go to the main business. So get ready with your pen and paper. Try to interact and try to post your answer. So first questions in front of your screen. A 32-year-old G1P0 woman who is 26-week pregnant present to her obstetrician for a routine prenatal visit. The pregnancy has been uncomplicated and patient's weight gain has been appropriate. Her blood pressure has ranged from 105 to 90 to 1 to O/85. Her urine has not shown any proteinuria and has been contained only trace of glucose for past two visit. During this visit, urinalysis reveals 1 plus glucosuria. The patient undertake her scheduled 50 grams of oral glucose tolerance test, which shows a serum glucose of 135 milligram per dl. Which of the following is the most appropriate next step in the management of this woman's probably diabetic? Dietary restrictions, exercise regimen, insulin injection, oral metformin, sulfonylurea. So your time starts now. You can post your answer. We'll discuss. I would be happy to interact with you. You can't see the question. Nobody can see the question. Is my question is visible? Yes or no? Anybody can please reply. Somebody is commenting me. I can't see the question.
So the
Question
it is
are
visible,
visible.
sir.
Visible, na? To all. Yeah. So Dr. Mifraz, I think you can adjust your screen. Everybody can see. That means something wrong at your end.
हम लोग 4 बजे दुकान पे रहेंगे
And you can mute your mic as well. If you are not interacting, you can mute your mic. You have the facility, or else I can mute all. Whenever you want to interact, you can unmute. Yes, Anjali, what do you think? Anjali, we'll start with you.
Sir, I think
What
it's A
was
only, dietary restrictions.
okay, dietary restriction. So what do you think? What's the diagnosis? So let me guide everybody right properly discussing this question. So now onwards, before starting in any MCQ, right? This is the triad for any MCQ, multiple choice question. Now onwards, you need to know three things for any MCQ. So for this MCQ, you need to know three things. First thing is what's the diagnosis. Second is to reach up to the diagnosis, what you gonna do means what's the investigation. In investigation, two things will come. They in sometime ask you in exam what is the initial investigation. They ask you what is the best investigation, what is the most appropriate investigation, what is most sensitive and specific. The answer is the same, right? And third thing is a treatment. So for any MCQ, you must know these three things. Until and unless you know these three things, you are not very much confident in solving any MCQ. So let's start. What do you think? What's the diagnosis for this patient, doctor? What's the diagnosis? Without diagnosis, nothing works, right? You need to have a clarity in your mind. What could be the diagnosis? So what's the diagnosis, doctor? Yes. Anjali, what's the diagnosis? Anyone? Anyone wants to try? What's the diagnosis? There must be some diagnosis to this question, isn't it? Right. So Dr. Zainab said it's a gestational hypertension and diabetes. So that's correct. So it's a gestational diabetes. So this is the gestational diabetes. So now when the patient has a gestational diabetes, right, means during the pregnancy they develop the diabetes. What's your advice? I mean, how you treat this patient, right? So correct answer is this woman has mild gestational diabetes. How you define? As a serum glucose concentration is more than 130 milligram per dl after 50 gram of oral glucose tolerance test. Right, so here 135, right? So the international definition by American Diabetic Association or International Diabetic Association is 130 after the GTT. So it is 130, patient has 135, so obviously she qualifies the gestational diabetes. The first line of treatment to control the blood glucose is the dietary restrictions, as Dr. Anjali said. So absolutely dietary restriction is the number one. You cannot bypass the advice of the dietary restrictions. Patients are placed on anti-diabetic association diet, which restricts the calorie and adhere to the convenient food pyramid. So there is a food pyramid. You go and look into it. ADA, that is American Diabetic Association Gestational Diabetes, which suggests the following target for women testing blood glucose level during pregnancy. Before a meal, it should be 95 or less, 1 hour after 140 or 2 hour after. This is the targeted. This is the value of normal. If something alters here, it is considered as a gestational diabetes. Why the not the answer is B, exercise regimen. So dietary restriction is more important than exercise regimen. But the important thing is if you add along with the dietary in combination with the regimen, the control of sugar or GDM is much better than only diet. But rest dietary restriction is first and foremost. You cannot bypass. Third thing is why not it is a insulin. So insulin injection is only helpful when the dietary restrictions exercise gets failed, then that would be the most appropriate treatment. So diet control is the first line of treatment for GDM and followed by insulin injection, but not first. D and E both are oral hypoglycemic agent and they are not a good drug of choice in gestational diabetes because of potential risk of hypoglycemia to a baby, right? So that is the thing. So this is how we have to see do. So your job in the exam is not just to give the correct answer, but your job is to get the real answers as well, right? You need to know the answers as well, right? So why A, right? So once you are giving the answer A, right, that means you have to also figure it out why it is not B, why it is not C, why not it is not C, right? So this answer is correct, perfect, but why not this, why not this, why not this? You must know. You need to make a practice now onwards. Why insulin is not first line treatment? Why oral hypoglycemic is not first? Why the dietary restriction is first? So you need to explain yourself, right? You don't need to mug up. If you understand the concept, you can answer any question. That's all. So this is one question is done. Check your score, what you answered and what is the real answer. So you get to know your score. Second question is in front of your screen. Mifepristone is an effective abortifacient if given within 72 hours. Means it is a effective drug which induce the abortion. That is abortifacient. Means it cause the abortion. So mifepristone is an effective abortion inducing agent if given within 72 hours of intercourse. Mifepristone contains which of the following? Estrogen and progesterone, high dose estrogen only, progestin antagonist, progesterone antagonist, progestin only, or prostaglandin, right? So your time starts now. You can think and get the answer. Yeah, we are more than 20-30 people in the class. I'm just getting every time 2-3 question answers. So I want you to answer well. Yes, Dr. Zainab, any comment? Dr. Zainab, any comment? Anyone? I wish I would be happy if you interact with me, right? Just sitting. Okay. You like to chat. Okay, fine, fair enough.
Sir,
Doctor,
it could be progesterone.
yes, sorry.
Progesterone.
What is, I mean, what's your answer?
I guess D, progesterone only.
Who said D?
Sir, can you hear me?
Yeah, I can hear you, doctor. What's your name? Sorry, I just.
Dr. Shagufta.
Okay, fine, great. So do you think it's a progestin only? So
Um,
have you ever used in your practice, doctor, this mifepristone? Is it allowed in Pakistan, or is it banned, or it is legally, I mean, allowed or not? I'm just trying to understand. Huh?
Sir, I have heard about it once. So
Okay. So
I guess it's
are you doing any practice in gynec or OBGY, or just your
no, sir,
specialty
no,
is
sir,
bit different?
no, sir. My
Your
specialty is different.
specialty is different. Fair enough.
I
Okay.
guess this is progesterone antagonist.
Yeah, so that's correct. That's the real answer, doctor. It's a progesterone antagonist, not the progestin only, right?
Yes,
So
yes, yes.
mifepristone is the drug which induced the abortion, probably some rape victim, say for example, unwanted sexual intercourse, have a pregnancy, right? And obviously it's not legal, right? So you need to abort the baby. So amongst this, mifepristone is a very effective abortifacient drug or abortion inducing drug. So it is very commonly used here in this part of the world. Mifepristone is an anti-progesterone or progesterone antagonist that has been shown almost close to 100% effective at preventive pregnancy when given within 72 hours of intercourse at one time of dose of 600 milligram. So it's a very important. The high efficacy of mifepristone compared to other regimen is likely secondary to its ability to inhibit the implantation. So mifepristone is anti-progesterone. It not just the inhibit the implantations of ovum, and it also inhibits the ovulations as well. Means from release of the this ovarian cells from the ovary as well, ovulation. Right. So this is what the mifepristone is. So you must know this is very commonly used drug across the globes, right? So go and read about again more literature of mifepristone, right? It is used in it used as a abortifacient as well as, and sometimes it is used as a contraceptions as well, right? Especially after unwanted intercourse, right? So second question, 2 out of 2 is excellent. The score, just check your score by your own. Third question in front of your screen. Which of the following is not true about heparin-induced thrombocytopenia? So A is HIT means heparin-induced thrombocytopenia. So HIT type 1 is non-immune and type 2 HIT is immune. HIT type 2 can cause thrombosis. Unfractionated heparin UFH is unfractionated heparin. Can cause low platelet but not the low molecular weight heparin. Observation is treatment in type 2 this HIT. All of the above statements are true. So you need little hematology background knowledge. Not very difficult but important. Yes, Dr. Varun. Let's start with you. You posted the answer C. So I want to know what do you think about this heparin-induced thrombocytopenia and how you define one versus two. Varun,
Uh, Sir,
whatever you knows, you speak.
yes,
Yeah.
sir. Sir, any heparin product, whether it's low molecular or whether it's unfractioned, it is contraindicated. So I straight away went for option C.
Okay. So you think that unfractionated heparin can cause low platelet but not low molecular weight heparin?
Yes, sir. Any heparin product is contraindicated.
So you posted the answer C. So answer C is correct or wrong?
Which
This
of the following
statement is
does?
correct or wrong? Unfractionated, the C options, let me tell you once again, just to get you the better clarity. What I am asking, say you selected the answer C, right? So what
Mhm.
is the answer C is, right? That unfractionated heparin, right? Unfractionated heparin, right? Can cause low platelet but not the low molecular weight heparin. So low molecular weight heparin does not cause thrombocytopenia and unfractionated can cause thrombocytopenia. Is it true or wrong?
That is false, sir. Both can cause thrombocytopenia in heparin-induced
Fine.
thrombocytopenia.
Then why you selected C? Okay, anyone, let's think over it. What's your you have a liberty to change your answer if you wish, huh? Because considered if the same questions comes in your exam, how you gonna respond? These all are absolutely from past papers, believe me. So I did a lot of hard work to compile all with answers and explanation and to make you understand well, right? So you need to. Dr. Dilakshi, any comment on this? Have you ever seen or worked in ICU where you had given any patients heparin and what happens to the platelet or platelet gets down? What do you think?
No, so I haven't worked in the ICU.
Right.
I have
So
little exposure in hematology, sorry.
hematology.
Yeah.
Wonderful. So this is hematology question, doctor.
No, it's
Very nice.
a
What do you think? If the same question comes, are you preparing for DHA?
no, sir.
Then what?
OMSB.
OMSB. So if the OMSB Pearson asks these questions, what will you answer? You need to answer something, na? Right or wrong, it's different story, but you need to answer. I advise and urge each and everybody, don't never ever make these questions blank. Whatever it comes to your mind and heart, you post something. Don't keep it blank, otherwise your mark is gone, right? So we don't need to lose any this. Dr. Reshma Jamil, any comment, doctor? Dr. Reshma, any idea on these questions? Yes. Dr. Priya, any comment? Dr. Priya, any comment on this? Anyone? I want to understand. I don't need you to mug up the questions. I want you to absolutely understand. Though I mean, discuss the few questions, but that would be 100% rock solid.
Could be C, sir. Just
What,
guessing.
Dr. Priya?
C.
Can you speak little louder if you don't mind?
C, sir. Option
C.
C.
Right. So low molecular heparin does not cause the thrombocytopenia. This is what you think? Fine.
Yes, sir.
Yeah. So your answer is wrong anyway, but I'll explain you, right? So just concentrate on this, right? So heparin induced thrombocytopenia. The name itself suggests heparin. After administration of heparin, right, injection, you get a thrombocytopenia. So once you give to the patient where the heparin is commonly used in our practices, like mainly in the ICU, right, or in the high definition unit or post CABG or cardiac unit, where heparin and anticoagulator is I mean, everyday's game, right? So heparin and this thrombocytopenia, if you want to see, go and check your ICU, talk to your ICU registrar or intensivist, he will tell you, right? Incidence and prevalence. So heparin induced thrombocytopenia is what? That when you administer the heparin to a patient, it will cause the thrombocytopenia, right? There are a lot of questions: when it happens, how it happens. So this is classified in two ways: heparin induced thrombocytopenia type 1 and heparin induced thrombocytopenia type 2. There are the two classified thrombocytopenia because of heparin. What's the difference between 1 and 2? This is 1 and 2. So heparin induced thrombocytopenia 1 is non-immune. So there is no immunological reaction, and this is a immunological reaction. So this is the biggest difference between 1 and 2. What happens here? Once you give the heparin injections, right? Earlier the platelet count of patient is 200,000 or 2 lakhs or 2 lakhs, right? After giving the heparin in 1 to 3 days or 4 days, right, the platelet counts get from 200 to say 145,000. So platelet gets down. This is from first 1 to 3 days or 4 days, right? Immediate effect. Once you give the heparin, it is not, there is no immune reaction. It is non-immunological. So it does not require some antibody to form and then destroy the platelet, right? You give it directly, it acts on the heparin, acts on the platelet, and it reduces the platelet, right? So this is a 1 to 3 days, and this usually develops after 4 days onwards to 15 days or even beyond 15 days. You get a thrombocytopenia, right? Here, why it's 4 days? Why not earlier 3 4 days? Because once you give the heparin here, it produces a heparin platelet factor 4. It develops antibody against heparin platelet factor 4. This heparin, once you inject, it will develop antibody against this. right? And antibody will take time, right, to form and act on the platelet. So here 4 to 5 days or 5 to 15 days at least it will take. So what happens when the patient comes to you in emergency room, right, with the acute chest pain, acute myocardial infarction, you had given the heparin, and immediately on the next day platelet count is from 200,000 to 100,000. It is likely type 1. Why? Because within 24 hours it gets down. But what happens here? The platelet day 1 normal, day 2 normal, day 3 normal, day 4 normal. But day 5, all of the sudden from 200,000, it becomes only 80,000 on day 5. Likely it is immune mediated. So this is one difference. Non-immune, this is immune. This is a 1 to 3 days. This is 3 to 5 days, right? Another important thing is the incidence and prevalence is up to 30% of the patient develop. Here little less percentage in clinical practice. Incidence and prevalence is less. It is less dangerous or non-dangerous, and this is life-threatening. Patient will die life-threatening. We recently treated one patient with thrombocytopenia, came from United Kingdom and posted for some bypass surgery. Given this, and patient developed the heparin-induced thrombocytopenia type 2. We given direct thrombin inhibitor. We imported the drug DIT. Direct thrombin inhibitor is a drug of choice. We had given and saved the life. Here there is just thrombocytopenia, low platelet count. Here low platelet count as well as thrombosis. This is the biggest. You are surprised. How come, sir, thrombosis is there in patient of thrombocytopenia? Because thrombocytopenia is a low platelet, and low platelet you must have the bleeding. And you are saying, sir, this patient has a thrombosis? Yes, thrombosis. Because this platelet factor 4, heparin platelet factor 4, will release a chemical from the platelet, and it makes a clotting of the platelet, coagulation. It adheres the platelet with each other and make a clot. So thrombosis, patient will die because of thrombosis in heat 2. Let me tell you, not because of bleeding, right? So this is what the thing is. So this is real literature, right? This is real literature. And let me tell you, the things will be more clear. So here heparin induced thrombocytopenia, right? It's a non-immune, as I told you. This is immune. I told you epidemiology, 30% of the patient, right? Unfraction heparin, right? They also develop, and Dr. Priya, low molecular weight heparin, they also develop this, right? It is less common with LMWH, means low molecular weight heparin. The brand name is Clixen. You must have heard Clixen, enoxaparin, right? This is a low molecular weight heparin. So not just only the unfractionated heparin can cause, also low molecular weight heparin. So as rightly told by Dr. Varun, any form of heparin, any form, whether low molecular or high molecular or unfractionated, wherever heparin contains, it can cause thrombocytopenia. That's it. So what's your main job in heparin-induced thrombocytopenia is no heparin in any form, whether low molecular or high molecular. So completely clear the concept in your mind, right? What's the pattern of bleeding or what's the pattern of thrombocytopenia? It is from 1 to 4 days of initial. So once you start the heparin in 1 to 4 days, here 4 to 10 days or even beyond 10 days, platelet count is usually not less than 100,000. And here the platelet count could be 60,000. In our patient, it could be somewhere around 30,000. After giving the heparin in the cardiac unit, 7 8 days, I got a call. Suddenly, unexplained platelet falls. It is very difficult to diagnose because you never get a strike in your mind. This is heparin induced thrombocytopenia. So whenever I am going to the ICU and there is a low platelet reference to me, I don't want to miss is HIV. Second is heparin induced thrombocytopenia. Third is TTP, thrombotic thrombocytopenic purpura. Fourth is HUS, right? And fifth is leukemia. This is properly, I mug up this. So whenever I'm entering into the ICU and somebody saying, sir, platelet count is low, you have a reference. I rule out HIV, heat, TTP, HUS, that is hemolytic uremic syndrome, and leukemia. This is, I don't never, and drug, obviously, in the ICU, drug interaction is a lot of. So these things I never ever want to miss. One of them is drug, and this drug is heparin in the ICU. So heparin is also important. Antibody mediated, no, it is not, because it is a non-immune, so no antibody. It is a immune mediated. So antibody mediated, yes, it is thrombosis is common, no, it is not common in HIT1. Common, yes, it is, because patient die because of thrombosis, not thrombocytopenia. Management is nothing. You just observe, you stop the heparin in any form, low or high molecular. Here you can, here just stopping the heparin is not solve the problem. you need to start the treatment with DTI, that is direct thrombin inhibitor. So here just you stop the drug. That's it. You don't need to do any intervention. You stop the drug, platelet will count again from 100,000 to 200,000, which will come automatically by its own without intervening anything. But what happens in type 2? Once you discontinue, you can't keep wait and watch. You need to give some drug which dissolves the thrombosis, and that is why direct thrombin inhibitor. Thrombins means thrombus, thrombus means clot. So you need to give some drug which dissolves the clot, that is called direct thrombin inhibitor or direct clot inhibitor. You need to give an outcome. It is self-limited. If you don't do anything, it will resolve by its own. And here the first thing is death, directly death. How come death? Arterial venous thrombosis. So this patient will die if you don't do anything. So this patient either die because of cerebral thrombosis. I had a patient whom we treated. We had unfortunately very bad clot sitting in the left or right atrium. So there is a big, we did a echo, we did lower limb venous Doppler. So he has a DVT in a venous, he has a thrombus in the heart. So if we do anything, it will die because of some this thrombosis to the patient. So fortunately, thank God that we had given the direct thrombin inhibitor to this patient and survive. Touch wood, it is fine now and in the follow-up. That's it. But no heparin for lifelong for this patient, right? So you cannot rechallenge the heparin in future, right? So you need to explain to the patient, right, that this heparin-induced thrombocytopenia is a death-leading complication of heparin. It is not very frequently seen in our practice, but we get a call probably twice or thrice in a year. So not very frequently, but still you need to keep in mind. Is that clear? Dr. Priya, any question?
Clear,
Dr.
sir.
Priya, any questions? It's all clear. This slide, I think, is a self-explanatory slide, isn't it? So it's all clear. Any question?
No, sir.
So now go back to the question, right? Revise your question, revise your answer, right? So heparin-induced thrombocytopenia, not correct. They are asking what is not correct. What is not correct, right? They are not asking what is correct. They are asking what is not correct. So heparin 1 is non-immune and heparin 2 is immune. Yes, it is correct. So this is not the answer. They are what they are saying, not true. This is true. Heparin-induced thrombocytopenia can cause thrombosis. Yes, it can cause thrombosis. It is true. On fraction or low molecular and high molecular, right? On molecular fraction heparin, right? I'm coming to you, Dr. Jamal. On fraction heparin can cause low platelet, but not the low molecular. So this is wrong statement. Low molecular can cause and on fraction can cause. So this is the answer. What they are asking, right? Not true. So this is not true because low molecular and everybody can know, right? And this is also a correct answer, little confusing. Observation is a treatment in heparin type 2. No, never ever. Heparin induced thrombocytopenia, it's not observation. You need to give direct thrombin inhibitor, right? In one, just observation. If it is one, it's observation. All of the statements are true. No, it is not true. So that is what the thing is. Yes, Dr. Jamal, you raised some hand. So ask your queries. Yes, Dr. Jamal. Do you have anybody has any question?
So
Shall I
at
move
last
ahead?
the answer is COD, sir. That
I think both the answer because unfractionated heparin can cause low platelet but not LMWH, right? So LMWH can also can cause. So answer here two answer. Two statements are false, not true. This is not true, right? Because low and molecular and unfractionated both can cause thrombocytopenia. And here they mention not LMWH. So LMWH can also cause. So this is the answer as well as this is also answer. D is also answer. Observation is treatment. No, it is not a treatment. If you can see the slide, what is the treatment management? Not just the observation, you need to give the direct thrombin inhibitor as well. So here two answers, C and D. So those who answered C and D or both are correct. But A and B is absolutely wrong answer. That's it. Yes, any questions? If you don't have any question, let's move ahead with the fourth question. So three questions. If you have two answer, it's good. If you have all three wrong, it's not good idea. Work more on your case. A 22-year-old college student present to a student health center because of 10 days history of headache, malaise, low-grade fever. He also complains of non-productive cough for the past 7 days. X-ray shows peribronchial infiltrates, what is the most appropriate empiric treatment you will gonna start to this patient? Amoxicillin, azithromycin, ceftriaxone, penicillin. I need three things. What's the diagnosis? What's the investigation? What's the treatment? And how you manage this patient? You go ahead. Yes, Dr. Rashid, what's your comment, Dr. Rashid? If you can interact, I would be glad. Dr. Rashid? Yes, Dr. Jamal, you are raising hand, but I think I cannot get your voice. So how we can interact?
Sir,
Yes,
the
Jamal.
answer would be B, azithromycin.
Azithromycin. Okay, fine. So let me ask you three things again. Without triad, I will not go ahead with any question. So what is the diagnosis first of all? Because they had not
Atypical
given
pneumonia.
Pneumonia, sir.
Atypical
pneumonia,
pneumonia.
specifically atypical pneumonia. So
Yes.
let me ask you, Dr. Jamal. So atypical pneumonia. How you diagnose atypical pneumonia? What's the investigation? How you get to know, right? What investigation when you suspect any patient suffering from pneumonia? What usually the investigation you're gonna send to your patients?
Sir, X-ray, first of all. Chest X-ray is
X-ray.
very mandatory.
Okay, fine, fair enough. X-ray is obviously the basic investigation. So X-ray you will send. What else you
And
send?
CBC. CBC.
And CBC. Okay, what else you send? Chest X-ray, CBC.
Sir, we
CR.
can send sputum. We can send sputum, but the patient is not having non-productive cough. So we
Fine.
cannot send sputum for
Fine. So
culture and
patient has
all.
no non-productive, so sputum may not come, maybe dry cough, right?
Yes.
So
Yes.
non-productive cough, but you can send if it is a sputum, otherwise not. Okay, fine. So you get to know
Also
that
blood
okay,
culture.
and blood culture, excellent blood culture. So these are the key investigation you're gonna send for this patient, right? So
CRP
somebody who
also.
came CRP also we can send C-reactive protein, right? Somebody is suspecting tuberculosis, so he can send the ESR as well, right? Just the
Yeah,
benefit of
exactly.
doubts. So this patient is a young, especially this is not old, 22 years of old student came to the health center. He has a short history, 10 days history of headache, malaise, low grade fever, and non-productive cough. So fever and cough, malaise headache. So malaise headache can be because of fever. When you had a fever, you probably have loss of appetite, malaise, headaches, right? But fever and cough is main. So you are suspecting some kind of chest infection or probably the pneumonia. For past days and chest X-ray, you get infiltrate, so likely it's a pneumonia. How did you get to know, Dr. Jamal, that is a atypical pneumonia? That is what I'm little fascinating to understand. How it
Sir,
is atypical, 100%.
clinically,
But I want to
sir,
understand the concept. How did you
yes, sir.
specifically tell that this is atypical pneumonia?
Sir, first of all, we start from the history. We
Okay.
used to ask the patient, like the sign and symptoms would be different in both.
Mm-hmm.
They would be
Mm-hmm.
less severe in pneumonia as compared to atypical pneumonia. Like he's having low grade
Atypical
fever.
is bad. Atypical is bad or typical is bad or both bad.
No,
Obviously,
typical is
both bad.
bad.
Any
Typical
pneumonia is
is
bad.
bad. Both are bad, but I guess typical is more bad. It's
Typical is so. This is a little better. Atypical is better.
yes, sir.
That is what you think. Okay, fine. So atypical pneumonia. Can you tell me what organism can cause atypical pneumonia? Two, three organism, if you remember.
Um, sir, they're like the names are
There
not
must
coming
be
in my
some
head right now.
there must be some bugs, right?
Legionella,
Pneumonia means
Klebsiella.
some right. There must be some bugs, right? There must be
Mycoplasma,
some back.
mycoplasma, sir.
So somebody told
Mycoplasma
mycoplasma.
pneumonia.
Okay, so mycoplasma is one of the atypical. What else? Another
And
Legionella,
there is mycobacterium.
right? Chlamydia. These all are the atypical. And recently, the COVID-19 is also atypical. Fungal is atypical. So fungal is not
What about the
atypical.
Klebsiella, sir?
Klebsiella.
Klebsiella also there. So these all are the atypical. You must know at least some bugs, right? Because your antibiotic will be directed to the bugs, right? It is not. If I tell you the fever with malaria, your mindset is different. Fever with this enteric fever, treatment is different. Fever with pneumonia, treatment is different. So bug. Whenever there is an infectious disease, the most important investigation is to find out the organism, right? So this is what the exactly the head-to-head comparison for typical versus atypical. I want you to understand well and learn well, right? Not just the mug up. So what is the typical? So typical onset, how it gonna start? So once patient has fever, headache, cough, this is short history, 2 days, less than 2 days. This is more than 3, 4, 5 days to start the symptoms. Age, any age, a typical development. This is usually in adolescence. Fever is usually high grade. In a typical here, low grade. This patient, our patient has a low grade fever, so this qualifies. Cough is usually typical productive. Here, dry cough. So our patient has a dry cough, so these symptoms are there. This is also there. On day 4, 5, he developed 10 days, right? So atypical. So three things are matching in our scenario. X-ray shows localized disease. Here, the diffuse disease like COVID-19 is a diffuse viral pneumonitis, right? Here, the organism is mycoplasma and lot more. And treatment here is a ceftriaxone, is a third generation cephalosporin. So now your homework is to find out what is first, second, third, fourth, and fifth generation cephalosporin. Third generation, which antibiotic comes? Fourth generation, which comes? Fifth, which comes? Which covers methicillin resistant Staphylococcus aureus? This is exam questions, not going much in detail, but you must know. That's it. And here the macrolide. Macrolide is what? Azithromycin is a macrolide. Azithromycin is a macrolide, and that is what the answer is in our question. So this is a community acquired atypical pneumonia, right? In a young boy, uncomplicated, patient's vitals are not mentioned, means normal. So out of these things, atypical pneumonia, azithromycin is the most sensitive and specific drug because this all three meant mainly for the typical, which covers the typical bugs, not the atypical. So azithromycin is the treatment of choice, right? That's it. That is what the answer is and explanation is. So let me go through the explanation very quickly. Epidemiologically, a young patient with these symptoms finding most likely atypical or walking pneumonia. The symptoms of atypical pneumonia caused by chlamydia, I told you, mycoplasma, somebody told, legionella, told, right? They present with non-productive cough and fever. This is most common presentation. Macrolide antibiotic are the preferred therapy for atypical pneumonia, and azithromycin is favored. We had given lots of azithromycin and doxycycline in a COVID-19 pandemic, right? I remember I had given thousands and thousands is azithromycin. Why? Because it is an atypical pneumonia. It was not productive cough, dry cough, fever, breathlessness, low SpO2, blah blah, right? Atypical. So azithromycin is a favored drug of choice. And why not? It's erythromycin and all, because amoxicillin, ceftriaxone, and penicillin not cover the atypical pneumonia. That's all. So this is what the explanation is, right? So you need to remember these basic things between atypical and typical pneumonia. So now onwards, whenever you see, you look for the onset, you look for the age, you look for the productive cough versus non-productive, local versus diffuse disease, and try to see it is typical or atypical. Then your job would be easy clinically to treat the patient. That's it. This is how I go. Fine, fair enough. So this is all. 4 out of 4 is excellent score. 4 out of 3 is a good score. Less than 2 is not good score. So check your score. Keep a watch on it. Question number 5 on your screen is a 45 years old woman. Any questions? I mean, I think if you are not asking means I considered as a granted that everybody understood well. So I'm going little ahead. A 45-year-old woman with unexpected weight loss. Unexpected. Doesn't expect, but she had a weight loss. Loss of appetite, shortness of breath present to your clinic on examination. There is a reduced air entry and dullness on the percussion in the right lung. A pleural tap is performed and aspirate sample sent for the analysis. You are told that the result reveal a protein content of more than 30 gram per dl. From the list below, what is the most likely diagnosis? Is it bronchogenic carcinoma? Is it congestive cardiac failure? It is liver cirrhosis, nephrotic syndrome, and mixed syndrome. Your time starts. Viral pneumonia, Dr. Varsha, sorry, I just seen your comment. So viral pneumonia, you just give the symptomatic treatment. Viral pneumonia, there is no specific treatment because we don't know the exact strain of virus like a COVID-19. So we are trying to avoid the super added infection to the patient. That is why we are giving the antibiotic like azithromycin in COVID-19. But there is apparently no specific antiviral drug for viral pneumonia, mainly the supportive care. Initially, if you know the exactly the strain of the virus, then probably you can target the virus. Yes, Jamal, Dr. Jamal.
Sir, it would be A, bronchogenic carcinoma, I guess. I'm not sure.
Fair enough. Well, just wait for 1 minute. So we see other experts what they are saying. I want to discuss, right? It's not just the answer and we go ahead. So tell me, Dr. Jamal, how did you thought of bronchogenic carcinoma, or tell me the point favoring in bronchogenic carcinoma? Tell me now. Start.
Sir, there was unexpected history of weight loss, and
Okay,
there's loss of
so
appetite.
fine. So shortly, can I tell that it is a constitutional symptoms,
Maybe
Yes,
right?
sir.
Yeah. So fever, weight loss, right? Reduced appetite, unexplained fever. These all are called in general is constitutional symptoms, and it could be either in infection or malignancy or cancer, right? So here they are saying already is a case of this. I mean, looks like a cancer patient, right? Or probably a cancer patient, right? So what do you mean? This 30 gram per DL is what? I mean, it is exudate, is it transudate, or how you differentiate between? Have you heard of word transudate versus exudate? Yes or no?
Yes, sir. It's transudate.
It's a
No,
transudate. So how you
X.
differentiate transudate from exudate? Tell me. I'll make a
Sorry,
border
sir.
between
It's
this.
exudate. It's exudate, sir.
Transudate,
Sorry.
exudate. Okay, so how you classify exudate and transudate? If you tap ascites, if you tap pleural tapping, if you tap the lumbar puncture, and you want to say
Yes,
this
sir.
fluid is exudate, this fluid is transudate, how you differentiate?
Sir, there are 4 5 things, starting from the color and the consistency and the TLC
So
count and protein count.
tell me the two specific things, only two specific things, irrespective of color, irrespective of smell, irrespective of appearance, whatever. If two
Sir,
things are there,
WBC
it is
count,
100%. No, it is not a
WBC,
WBC count. No, no.
protein count.
Yes. So one is a protein, you are right, and another thing is LDH,
Yes,
right?
LDH.
So these two things, protein, right? So this is a pleural fluid and serum fluid. This is pleural fluid and serum fluid. So protein, plural protein and serum protein, if the ratio is more than 0.5, it is exudate. If it is less, it is transudate. LDH, pleural fluid LDH and serum LDH. Pleural, directly you enter the needle into the pleural cavity, take the fluid and send for LDH. And one you take from the blood, that is called serum, right? So pleural LDH and serum LDH. If the ratio is 0.6, more than 0.6, it is a exudate. Less than 0.6 is a transudate. Is that clear to you? Yes or no? Yes or no? Right? Right. So this is like a 0.3 milligram per DL. So it is more than 5. So this is a exudative kind of things, right? So exudate is usually infective or malignant. Usually infective or malignant. Let me go to the chart, right? So and classical history is also, if you see, this looks like a malignancy. How you get to know that this is malignancy? What point favors you need to understand? Unexplained weight loss. It could be happen in other conditions as well, but in general, loss of weight, shortness of breath, something wrong in the lung, right? Dullness on the percussion. What makes the dull? What are the causes of lung dullness on percussion, Dr. Jamal? What what are the differential diagnosis? If I can tell you, tell me the three reasons where you get a dullness on percussion. There is a dullness.
Uh, Sir, usually in pleural effusion, we used to have dullness on percussion.
Okay, so pleural effusion. So when there is a fluid, pleural effusion, there is a dull, right?
Also, empyema.
Fluid, empyema. Then you also include the hemothorax as well, right? There is
Yep.
also a fluid, no blood.
Yes, sir.
So whenever there is a blood, whenever there is a fluid in the pleura, you get a dullness. And when there is a air, it is called as a hyperresonant.
Yes.
Hyperresonant.
Yes, sir.
And this is seen classically in, right? So when there is air in the lung, right? What it is called as a air in the lung? Air in the lung. Anyone?
Um,
Pneumothorax.
pneumothorax.
We forget the name, huh?
The
Pneumothorax.
pneumothorax.
So pneumo means air and thorax means in the thoracic cavity. So when there is a air, it is a hyperresonant. Don't get confused between these two words. So when there is a air, pneumothorax, right? When you had a chest injury, you had a bad pneumothorax, right? You when you auscultate, there is no air entry, and when you percuss, it's a hyperresonant. And when there is a fluid, when there is a blood, when there is a pus, there is a fluid in the wall cavity, it is a dull, right? So this is what the difference is, right? So they are already saying that this dullness, so some fluid is there, so it's a pleural fluid, right? They tap the pleural fluid and they send it, and protein is very high. It's a exudative type of pleural effusion, and this all B, C, D, E is a transudative. Only A is a exudative. That's it. Let's get back to the chart. It's a list criteria for pleural effusion. Exudative more than 0.5. See the pleural versus serum protein. So if the pleural fluid is 10 and serum is 8, so you 10 divided by 8, you go. If it is more than 0.5, it is exudative. If it is less than or equal to 0.5, it's a transudative. Same way LDH. If it is pleural and serum LDH, if you see less than 0.6, it's transit exudative. And see the cause of exudative: infection, malignancy, pulmonary embolism. That's it. So one of them is malignancy. Bronchogenic carcinoma is already a malignancy. So here the answer is bronchogenic carcinoma. Cardiogenic, congestive cardiac failure, right? They usually don't have the weight loss, rather they have weight gain. And pedal edema, right? Lots of fluid accumulate and they don't have the protein more than 30. Liver cirrhosis is again protein is less, not the high, because of hypoalbuminuria. Liver does not produce the protein, so it's a transudative. Nephrotic syndrome is transudative, right? And mix is also. So that's it. This is what the answer is. So bronchogenic carcinoma is the answer. So check on your score. 5 of 5 is excellent score. Dr. Jamal, is that clear?
Yeah.
Fine. So hopefully you are going well. Question number 6. A 67-year-old woman is admitted to the accident and emergency with pyrexia and a cough. Productive green sputum observation shows a pulse rate of 101, BP is 80/60 millimeter of Hg, respiratory rate RR is 32 per minute. She is alert, oriented in space and time. Blood results reveal WBC of 2100,000. Urea is 8.5, chest X-ray, so patchy consolidation on the right lung lower zone. She is treated for the community acquired pneumonia. Which of the following corrects calculated COP65 score? So they are asking in a community acquired pneumonia, right? They are asking you count the CURB score, CURB 65. I don't know whether you heard of CURB 65 or not, but if you heard, just calculate the score and tell me. Take your own time, 20-30 seconds, we'll discuss. Yes, Kaushika Kalai, can you little bit interact, right? How
Yes, sir.
did you get this? Yeah, so first of all, let's go to the basic, right? So you can answer me few questions if you don't mind, right? Probably a
Yes.
learning for you. So first of all, help me to define what is curve 65. So what is C, what is U, what is R, what is B, and what is 65? Go one by one.
You see, for confusion, she's alert, so 0 for it.
One second.
Okay.
Confusion. Alert. So by whatever you are telling, I'm putting the score 0. Your
Okay.
explanation is if confusion, score 1, right? If
Yes.
alert, score 0. Okay. U stands for?
Urea.
U stands for urea. Dr. Jamal, you can check your mic. Probably there is something wrong at your end. So urea. So what's the score for urea? If you
Urea
want to see. Yeah. So I
1.
will. Yeah. So I will share the numbers as well, right? 1. So what defines 0 versus 1? When you say 1, when you say 0.
Less than 7, 0. Greater than 7, 1.
Okay. So greater than 7 is 1. So it is 8 something, right? So urea is
Yes.
1. What is R stands for?
Respiratory rate.
Respiratory rate. So what respiratory rate? 0 when, 1 when?
Greater than 31.
Greater than
Uh,
31. So here you want to put it 1, right? So let's check what
yes,
the respiratory rate is 32. So you put 1, right? Fair enough.
yes.
What's B stands for?
Blood pressure,
Okay, so blood pressure. So what the score for blood pressure? 0, 1, 2,
90
what?
by 60.
Okay, so it's less than 90 systolic or less than 60 diastolic is 1, right?
Yes,
Right. So here we check at least what's the blood pressure, right? So blood pressure is 80, so it is a 1, right? Less than 90 or 60, so 1.
yes.
And what is 65 is?
Age,
What is 65 stands for in curve
age,
65?
age, age.
Kaushika,
Yes, sir. Age, sir.
age. So what is the score here? 0, 1 or 2?
1.
1. Why 1? What's the
Because
criteria to put 1?
more than 65, they are 67. So,
So more than 65 age is 1, less than 65 is 0, so it's 67,
yes,
so 1. Right? So score here by you is a 4, right?
yes,
Right?
sir.
0 plus 1 plus 1 plus 1 plus 1. So it is a 4. So it is a low risk, intermediate risk, or high risk. What do you think?
High risk.
High risk. So
Yes.
is there any criteria? So this is curve 65 will give us the score, right? So on
Yes.
score, why you want to do the score basically, right? Just to have some prognosis, right? So what if it
Yes.
is a 0 to 1 score? What it is 2 to 1
Outpatient.
score? Or what it is more than 4 score in any patient of curve 65? How you
Uh,
define, how you
Low risk 0 to 1, we treat in outpatient setting. 2 to 3 is inpatient setting, moderate risk. Greater than 4 is high risk. We treat in ICU.
fair enough. Excellent. So you, I think, very well expert in the curve 65. I'm very glad and happy. Wonderful.
Okay, sir.
Very, very wonderful. I'm very glad. So this is what the curve 65. I'll get back to you, Dr. Jamal. So curve 65 stands for confusion, urea, respiratory rate, blood pressure. Confusion means CNS
Sir,
involvement.
I just wanted to say sorry. This time I cannot hear you. I don't know what happened. Should I come online again and
Yeah,
switch off
you
this
can come
class?
on. No, no, you can rejoin. I mean, there is options of
Okay,
rejoin.
sir, I will
Click the link
rejoin.
again. Yeah, so C stands for confusion means neurological things, right? U stands for urea means renal things. So brain is there, kidney is there, respiratory rate there, blood pressure there. So all vital organs are there. If all vital organs are affected in elderly patient, it is CUP 65. Confusion 1, urea 1, respiratory 1, BP 1, 65. So in this patient, right, you need to count and calculate, right? So here, see the patient came in the emergency room, right? The now see the 67-year-old woman admitted to the emergency with pyrexia, cough, with green sputum. This is the vitals. She has alert and oriented, so she is not confused. So here the confusion is 1. So this is all the criteria. So 0 to 1 low risk, as Dr. Kaushika rightly said. 2 is intermediate, and more than 3 or 4 is high risk. So you can treat in early 0 to 1 score, maybe outpatient. You can give some antibiotic oral. 2, you probably admit, probably not admit, depends on the clinical condition, indoor versus outdoor. And 3 plus 4, absolutely admission in ward versus ICU. So depends on the vitals and clinical condition of the patient. So you must know in each and every patient, you need to calculate the COP 65. Whenever now onwards any pneumonia, community acquired pneumonia patient comes to your OPD, whether they ask or not, you need to count. Okay, let me check what is a COP 65. 01, don't get panic. Just prescribe azithromycin, whatever related antibiotics, send back home. Call after follow up after 3 days, 5 days, and call earlier if they are worsening fast, right? If they are stable, instruct them, advise them, counsel them, finish this course for 5 7 days, come back for the follow up. That's it. So don't get panic in every pneumonia. Just need to calculate the cup score, right? If cup score is low, low risk 0 1, no need to worry. Just reassure the patient, give the proper advice, and send them back home. That's it. Any questions to anyone? Any questions to anyone? Okay, that means no questions. I'll go ahead. Fair enough. So you need to know the COP 65. This is COP 65, right? So this is how the total score 0 1 2 3 4 5 outpatient, inpatient, and ICU. That's it. So this is all the same story. I'm not going to go in detail. 75-year-old man is admitted to the hospital with pneumonia several days after the start of antibiotic. He begins to have a diarrhea. The stool C. Clostridium difficile or Clostridium difficile toxin is positive and he started on metronidazole, which leads to resolution of diarrhea over a few days. 2 weeks after the diarrhea recurs and again presented with C. difficile toxin, again positive. What is the most appropriate next step in the management or treatment of this patient? Retreat with the metronidazole, use oral vancomycin, sigmoidoscopy now you want to do and treat because there is a pseudomembranous colitis, intravenous metronidazole because oral is not working, wait for stool culture, right, and intravenous vancomycin. You want to give the highest possible treatment to avoid the recurrent relapse. Yes, Dr. Kiran, any comment from your side if you can interact?
I only know about vancomycin in Clostridium difficile.
Okay, so you don't want to use the IV metronidazole or second time the metronidazole, and if not, then why not?
I think there is a resistance to metronidazole again, so we will go for IV vancomycin or
IV
maybe.
vancomycin, not oral.
Yeah.
So IV
Because
or
we have
oral?
not,
What's your answer? Sorry, let me finish here. I don't know your name because it comes as some iPhone. Your iPhone.
Yeah.
So what's your name?
Yeah, Dr. Sharma is speaking.
Okay, Dr.
Actually,
Sharma. Sorry, huh?
I
Yeah,
for vancomycin just.
fine. So finally, so if this questions comes in your exam, what will you took finally? Oral, IV, metronidazole, what? A, B, C, D, E. What will you tick?
Mm,
Forget about others' answer. What you trick? Because we
okay.
can't discuss with the people in the DHA room, right? You need to give your own answer. So what's your answer? It's a very common and frequently asked questions and day-to-day practice. Very common practical question. You treated somebody with Clostridium difficile, given metronidazole. After 2, 3, 4 weeks, again come with Clostridium difficile. What you gonna
Yeah,
do now?
vancomycin.
Sorry,
F.
intravenous vancomycin. Okay, fine.
Yeah.
Yes, Dr. Kiran. Now you go ahead. We'll discuss, doctor. 1 minute.
Okay.
I'll get back to
I,
you.
I will go for vancomycin orally because we have not given in this patient. So
Okay, so
my take is B.
okay, so you are B. Dr. Sama is F. So you are saying oral. She is saying intravenous. So now you tell me, Dr. Sama, what is the difference between oral vancomycin versus IV vancomycin, and when it's supposed to give oral, when it's supposed to give IV?
Mm, Actually, patient is already admitted and he have pneumonia and metronidazole we already given and again the patient is same symptom diarrhea and again positive for the clostridium. So I just think we should give vancomycin because it resists to metronidazole.
Fair enough. So
So
answer vancomycin is correct, but now the confusion between oral versus IV, right? So
yeah.
let me tell you, Dr. Sama, that
Mhm.
IV vancomycin is not effective in Clostridium difficile because it will not penetrate well in the intestinal mucosa intravenously, right? So
Okay.
here the drug of choice is oral, right? So your homework today is to go open up the Master the Board or any book, standard Harrison or Davidson, and read
Mhm.
just little chapter of see there are three names all same: antibiotic associated diarrhea, clostridium difficile, or
Mhm.
pseudomembranous colitis. All three are the same name, don't get confused. If somebody is told antibiotic associated diarrhea, same thing. Clostridium difficile, same thing. Pseudomembranous colitis, same thing. So don't get confused. You get my point, right? So
Yeah.
now you open up the book and read, right? The answer is the oral vancomycin. It is highly sensitive and specific. Once you already had a metronidazole not effective, just within a 2 weeks or so, again come back means metronidazole is not effective, not sensitive. You need to change the drug, right? So
Mhm.
the highest sensitive and specific is the vancomycin oral. Why oral? Because it has a good intestinal penetration, which is not the IV drug vancomycin. That is why oral. So recurrent
Okay.
episode of Clostridium difficile associated diarrhea are best treated with another course of vancomycin. Intravenous metronidazole is only used if the oral therapy cannot be used. So some patient has some contraindication, major operative surgery, intestinal obstruction, blah blah, right? When he cannot take orally, in that case only you give intravenous. Otherwise, you give everything orally in C. difficile, whether it is the first course of metronidazole oral, after metronidazole failure, vancomycin, again it is oral. Why not the culture? Stool is never culture for Clostridium difficile because it is simply not grown in the culture. So you need a different culture media, not the routine blood culture or stool culture will grow the Clostridium difficile. So it's not a good test, or that's not the answer, right? Because the difficulty in culturing the Clostridium difficile is to source the name of the organism. Endoscopy looking for pseudomembrane will diagnose antibiotic associated diarrhea, but it's not the treatment. Intravenous vancomycin is always a wrong answer for antibiotic associated diarrhea since it will not pass the bowel wall. Is that clear, Dr. Sama?
Yes.
So now the answer is oral vancomycin. So those who had given the different answer, it's wrong. The final answer of recurrent or second time or after failure of this, it's a oral vancomycin. That's the drug of choice. That's it. So you go and read it once again. It's a whatever 1 to 7 I discuss, all 100% high yield questions for exam. So
Okay.
even you repeat it once again, it will be beneficiary to you because they may ask little different questions as well, but I'm trying to compile all the questions under one roof because I deliver thousands of lectures so far. So I know what they ask. Depending on that context, I'm trying to create several questions in a one question. Is that clear? Right.
Yeah.
So question number 8. Which of the following is associated with the development of primary CNS or central nervous system lymphoma? So which of the following? Epstein-Barr virus, JC virus, Mycobacterium avium complex, previous irradiation or radiation exposure, or Toxoplasma gondii. So, which is associated with CNS lymphoma? Looks easy but tricky, isn't it? We never thought of this question, but it's in exam. You can guess any questions, right or wrong, because you need to answer in exam. You can't just keep it blank. Blank means
Yes, sir.
zero. Sorry.
Epstein-Barr virus.
Epstein-Barr virus. Yes, Dr. Priya. So that's correct. You are absolutely right. So answer is Epstein-Barr virus. So can you tell me something about Epstein-Barr virus? What this virus is all about? What else apart from this CNS lymphoma? What else the EB virus can cause? Can you remember something? Apart from CNS lymphoma, what else the EB virus can cause? So that's your homework, Dr. Priya. You go and read it because there are lots of questions related with the EB virus. Those who cannot able to answer my this question along with primary CNS lymphoma, what else or what other pathologies or disease can cause by Epstein-Barr virus? So not going much in detail, you go read something, right? So tell me, post it in our group so everybody will learn, including myself. I need to also learn a lot of things from you. So post it in the group so I will also learn. Virtually all cause the primary CNS lymphoma in patient with HIV associated with Epstein-Barr virus, right? And before the use of highly active heart or ART treatment, CNS lymphoma was 1,000 times higher among HIV positive patient with the general population. And symptoms of CNS lymphoma, we are not going in detail anyway. So that's it. So JC virus is not associated with this CNS lymphoma. Again, Mycobacterium avium is not associated with CNS lymphoma, right? And other Toxoplasma gondii is also not associated with this CNS lymphoma. So last few questions. Question number 9, 30-year male with chronic diarrhea, anemia, and raised liver enzyme most likely associated with, or what antibody could be present in this patient. So before jumping to the answer, you must know what is the diagnosis. So if you don't know the diagnosis of this patient, it's difficult time for you to decide this antibody. So first you need to our triad again, diagnosis, investigation, treatment, right? So 30 years male, chronic diarrhea, also has anemia, also has some liver enzymes elevated, right? Right. So what's the diagnosis? And to prove that diagnosis, what could be the option from this four? What's the answer? We are more than 40 people. In the
Celiac disease would be
Yeah, Priya.
celiac disease.
Sorry,
Celiac.
your voice is so low, doctor. I'm little struggling to get the voice. Can you make little mic closer or some your headphone little closer so I can
Celiac
interact you?
disease.
Celiac disease. Okay, so this is you think that this is celiac disease, right? Fine. So how do you get to know this? This is a celiac disease. What points or what are the presentation of celiac disease? How the celiac disease present? Is there any other name of the celiac disease?
Um, there's two symptoms here, diarrhea and anemia. Main.
Sorry, your voice is breaking. What's the thing? You can type down in the chat box. I think your voice is breaking and little very low. Anyone else want to try, Kiran? Dr. Kiran? Are you agreed with the celiac disease? What the doctor Priya told? Celiac disease.
Yes, sir. Celiac
Sorry,
disease and antibodies. Yes,
this
sir.
is celiac
Celiac
disease.
disease. Yeah.
Okay, so what's the presentation of celiac disease? How the celiac disease present?
Diarrhea
Diarrhea. Okay. What else?
and thing,
Sorry.
coating. Basically, gluten sensitivity.
Gluten sensitivities. So gluten sensitivity or gluten hypersensitivity. So you give the gluten or you don't give the gluten to this patient.
We avoid gluten in these patients. That's the
So you avoid the gluten, right? Gluten containing food, right? Because it precipitate the disease, right? So celiac disease, right? So how you diagnose the celiac disease? Which is the best investigation to diagnose the celiac disease? Give me only one investigation which confirms that it is 100% celiac disease.
Small bowel biopsy.
Sorry? Yes, Dr. Kiran,
biopsy.
what's your answer? Biopsy. So biopsy, right? So biopsy is the main thing. Once the biopsy is confirmed, you need to do some kind of antibody to confirm this. So which antibody you will going to do in a suspected case of celiac disease?
TTG.
B.
B.
Anti.
Endometrium.
Yeah, anti-endomysial antibody, right? So anti-endomysial antibody is for celiac disease. Now, can you tell me, Dr. Lakshmi, where the anti-mitochondrial antibody is used and where anti-smooth muscle antibody? In which disease anti-mitochondrial antibody you use? In which suspected diagnosis that anti-mitochondrial antibody is positive? Like in celiac disease, anti-endomysial antibody is positive. This antibody is positive in which disease? Anti-smooth muscle antibody is positive in which disease? ANA is positive in which disease? So this is how we have to work in our practice while you are doing the mock test or solving the questions, right? So our job is not just to give the correct answer, right? If they ask, they change the question and they ask, in which disease anti-mitochondrial antibody is positive, then you must know what disease, right? So you need to know all four things, right? Not just one the answer. I'm happy at least you had an answer. I'm very glad. So this is what the thing is. So
Right.
anti-endomysial antibody. So celiac disease is autoimmune disorder characterized by inappropriate immune response to the gluten, right? A protein found in wheat and related dietary proteins in rye and barley. Celiac disease antibody tests are a group of assays developed to help diagnose and monitor the disease and few other gluten sensitive conditions. This test detects the antibody in the blood that the body produces and part of immune response. Right. So basically, celiac disease, this anti-endomysial antibody is present. Anti-mitochondrial antibody is highly sensitive and specific for the primary biliary cirrhosis. So that is the answer. So if they ask you in the exam anti-mitochondrial antibody, it's a primary biliary cirrhosis, right? And third thing is anti-smooth muscle antibody is highly or high level of SMA. Smooth muscle antibodies are usually seen in chronic, right, or long-lasting liver condition or hepatitis, right? So let me ask you the questions, Dr. Kiran, if you could answer. If you have one patient in your OPD, right, and is asymptomatic patient, nothing, no, absolutely asymptomatic patient, and you do some profile and AN is positive, what will you do? What's the treatment? Asymptomatic patient, ANA positive, what's the treatment? Question in exam.
Not treatment needed. He cannot do anything. He will
Okay, so no
wait
treatment,
and
basically no
observe.
treatment. Okay, fine, excellent. So this is the answer. So asymptomatic ANA is cannot be treated. Why? Because ANA is positive in 5 to 15% of the cases. It is present in a normal individual as well. So if somebody check the Dr. Munjal's antibody and do the ANA, and if my ANA is positive, I'm asymptomatic. Nothing to do, just monitor. That's it. Nothing to do, right? So asymptomatic should not be treated, right? Should not be treated. And many a times patients are symptomatic, but ANA is negative. Sometimes patients are symptomatic. Here asymptomatic, it is positive. Reverse, here patient is symptomatic, but ANA is negative. So it is not autoimmune disease. It could be something else. So we need to keep in mind. And ANA is positive in what condition? ANA is positive in what condition? Anyone? If you have ANA positive, anti-nuclear antibody positive, what are the condition where you get ANA positive? Anyone?
SLE.
Okay, excellent. First is SLE. So in SLE, ANA positive. What is the most sensitive and specific test which confirms the SLE?
Double-stranded DNA.
Excellent, wonderful, 10 out of 10. Anti-dsDNA, anti-dsDNA, double strand DNA. So this is the answer. So ANA can be seen in SLE, but once you SLE, if you are suspecting clinically patient as a SLE, fever, joint pain, ESR, CRP, blah blah high, you suspect it is SLE, malar flush, then you do the ANA. If ANA positive, confirmatory test you need to do. So this is, you can say, initial test. This is, you can say, confirmatory test. Is that clear? Yes or no? Tell me at least yes or no.
Yes,
Right?
yes.
So this is SLE, right? Another is a SJ, Steven Johnson, mixed connective tissue disorder, Jogren, vasculitis. These are all condition in which you can see ANA positive. So ANA is just the screening test. It's not a diagnostic test. Like ESR. ESR positive means what? What's the diagnosis? Nothing. ESR can be raised in chronic anemia. ESR can be raised in multiple myeloma, tuberculosis, chronic infection, inflammation, autoimmune. There are a lot of conditions where ESR, temporal arthritis, where ESR raised, but it is not diagnostic of anyone. There are a lot of differential diagnosis. Same way, ANA, lots of differential diagnosis. I compiled a list of the differential diagnosis. You can see it here. So condition where the positive ANA test include SLE, Sjogren, scleroderma, RA, polymyositis, MCTD, mixed connective tissue disorder, juvenile arthritis, dermatomyositis, polyarthritis nodosa, vasculitis, autoimmune hepatitis. So you see the chunk of the disease where you get the ANA positive. So only ANA positive does not solve your problem. You need to find out the specific antibody to answer the disease. And this is what the pathology in celiac disease. I love a picture a lot, so I every time post a lot of pictures in my MCQ. So this is normal intestinal mucosa. This is a normal. You see the very finger-like projection. This is absolutely normal, right? And in this is normal. And what happens in celiac? There is a atrophy. This is gone, right? So this is mucosal surface is gone because of gluten sensitivity. So the absorption of vitamin, absorption of protein, absorption of nutrient cannot take place at this level. So patient has anemia, patient has thrombocytopenia, patient has megaloblastic anemia, patient has weight loss, patient has steatoria. There are a lot of things, right, in celiac disease because absorption gets affected because of villus atrophy. Atrophy means the ciliary functions and absorptive functions is gone from the intestinal mucosa. So this is a celiac disease. So keep in mind, and this is how we need to answer. So those who did not never ever read the celiac disease, one of the most hot favorite question in exam. Last but not the least, 57-year-old woman who underwent emergency cholecystectomy for a perforated gallbladder 3 days back, now presented with fever of 103 and complaining of chills. The patient has not been ambulating and says she is a great deal of pain at her incision. What is the most likely cause of fever? So this is basically a post-op patient, post-op fever, cholecystectomy done 3 days back, now presented with 103 fever with chills, right? Patient is bedridden or not ambulating. He has a lot of pain at the site of her incision from where the cholecystectomy done, and now patient has fever. So what could be the cause of fever? Atelectasis, UTI, wound infection, deep vein thrombosis, abscess, or anything else?
Mm, wound infection.
Okay, so now you tell me what
Immunopathology infection.
is the one minute later. So how did you know that this is a wound infection, doctor? Tell me.
Just I just see the fever, so that's why.
Okay,
After after surgery, the patient has fever high grade. So
okay. So do you know the time frame of the fever? Day one post-op fever, what cause? Day two, what cause? Day three, what cause? Day four, what cause? Yes or no?
no, 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 just no.
You don't know, right? So there
Yeah,
is a one algorithm, right? If somebody develop the post-op fever, what could be the cause in terms of time frame in the terms of days, isn't it? So
yeah,
you know or you don't know? What's your name? Sorry, I forget.
yeah. Dr. Sharma, I don't know. Actually, I
Okay,
forget.
okay,
Yeah.
fine, fair enough. But I will make you remember, and if once I explain you, you will not forget lifelong. Believe me, lifelong, you will not forget.
Okay.
So next 2 minutes, you will be an expert of post-op fever, right? So let me tell you before answering the things, right? This is how I remember. You probably remember in that way. So post-op fever, post-op fever. So whenever any question comes with the post-op fever, you need to just see the only post-op day. What is the post-op day, right? So we start from the upside. This is the body. Can you see this cartoon? Yes or no?
Yeah.
Right?
Yeah.
There are five W. One is a wind. Wind is in the lung, right?
Mm-hmm.
Here below urinary bladder. So there is a water. That is W. In water there is W. In wind W. Third below is a leg, means walking. Then wound, anywhere in the wound body, that is a wound, that is W. Another W, weird or drug. This is how you have to remember. If you mug up, you will 100% forget. This is how remember. Go from upside to down. Wind, water, walking, wound, weird. So this is called 5W. 5W. This wind means something wrong in the lung that can present in first 1 to 2 days or max 3 days, usually 2 days. So post-op day one, post-op day two, if somebody develop the fever, think of the wind. Wind means air. Air is where in the lung. So pneumonia or atelectasis. These are the two causes, pneumonia or atelectasis. To prevent this, what doctors do? Do the aggressive chest physiotherapy, do spirometry, and give the prophylactic antibiotic. These three things done before surgery by the doctors. Is that clear?
Mm.
Yes or no? At least tell me yes or no. Yes
Yes.
or no?
Yes. Yes.
Wonderful. So this is 1 to 2 day. Now they are saying 3 days. Here what the question 3 days? Water comes from 3 to 5 days. So answer here is water. Where is the water in the MCQ? Water is urine. Urine is UTI. Urine is a water. So here the answer is UTI. Every time they will not give you that there is a placement of catheter, removal of catheter, retention of urine. Every time it is not mandatory to give in the clinical context. Sometimes you have to apply your mind and brain, right? So 3 to 5 days it is a water. More than 5 days or up to 7 days walking. So if you don't walk, you develop the deep vein thrombosis, you develop the thrombosis in the abdominal cavity and surgeries. You develop the pulmonary embolism. This is all related with the thrombosis. So this is usually when the fever after 7 days. Don't think of pneumonia. Don't think of atelectasis. Within 7 days they develop. More than 7 days. If the days is 10 days, 10 days after fever they develop. I probably go for deep vein thrombosis or DVT is the answer, right? And after 7 days or uh, say 14 days or so, right? You can think of 7 to 14 days. You can think of infection, wound infection. Infection won't develop immediately. I mean, today you did a cholecystectomy, tomorrow there is a fever and it is a very bad abscess from the wound side. It never develop because bacteria needs some time to grow and develop a abscess. Take at least 5 7 days, right? So this is how you have to remember, right? So wind, water, walking, wound, weird. Weird means some drug, deep-seated infection, abscess in the abdominal cavity, post-op. This usually present after 2 weeks, 3 weeks, right? So this is how you need to remember. So here the day three means answer is a deep urinary tract infection. Let me give you the another chart. This is what we most likely, however, all the choices are possible, but this is the time frame. 1 to 2 days, as I told you, wind. Wind is a lung, is atelectasis, post-op pneumonia 3 to 5. Wind, water is UTI, pyelonephritis, nephrosis, renal stone, blah blah, long list, but primarily a UTI. 5 to 7 days, it's a walking, deep vein thrombosis, and then wound infections and weird, right? More than 1 week to 10 days, right? So this is what the time frame, and I got excellent chart from one of the book from the Master the Board latest edition. So this is explaining the same thing. Here is a wound, then water, right? Number wise, then they give wonder, walking, and wound, right? So this is all what I explained in a simpler way. It is in a grammatic way. They have explained. So by and large, the same thing what I explained, they put it on the page, right? So that's it. This is what the thing is. Last but not the least, last questions for today. 70 years. So is that clear, doctor? Sorry.
Yeah, yeah, it's clear.
So now I think you are expert, isn't it? My drawing will
Yeah,
help you in exam.
yeah.
So if you remember mug up, you won't remember. But this is how I remember from my school days. All right. So wind, water, right? Walking, weird and wound, right? So whenever my surgical resident in my round asks, I'm not a surgical guy, I'm a hematologist, but still somebody may ask, I just look at what is the post-op day, then I guess. That's it. Most of the time I'm right and I investigate accordingly. That's it. So 70-year-old woman present to accident and emergency with sudden onset of pain and swelling in the right knee. Her past medical history includes hypertension and hypercholesterolemia. She is currently taking aspirin, ramipril, and simvastatin on examination. She is apyrexial. Pyrexia is not there. And right knee swollen. There is a reduced range of movement in the knee due to swelling and pain. X-ray of right knee shows chondrocalcinosis. What is the most likely diagnosis? Is it gout? Is it pseudo gout? Is it psoriatic arthritis? It is reactive arthritis. It's osteoarthritis in a 70-year-old male. The exhaustive day. Yeah, post the answer. We are 30-40 people in the class. Post the answer. Consider that this all will come in exam. Believe me, you will remember me in exam because all will you see in your screen. Dr. Asmat, would you like to comment on the last questions? What is the difference between gout and pseudo gout? I'll come back to you, Dr. Jamal. Let me discuss with first Dr. Asmat Danish. Then I'll get back to you. Yes, Dr. Asmat Janis. Why you thought of pseudo gout? What point present or favors in pseudo gout? Why not gout? Yes, doctor. Dr. Asmat, if you can able
Sir,
to
here is
interact.
chondrocalcinosis.
Okay, so chondrocarcinosis is the pathognomonic of pseudo gout.
This is the point.
Okay, so that is a point. What other points? What other point favoring the pseudo gout?
Sir,
versus gout? Just for your clarity, I mean, answer is correct. Answer is pseudo gout in
no,
this question. But I want to understand why you posted pseudo gout. See, whenever you answer anything, there must be some point favoring in the clinical scenario which favors that, okay, this is pseudo gout, this is acute MI, this is pulmonary embolism, because things favoring in the MCQ, no? So you look at the age, look at the sign, look at the symptoms, look at the investigation. If everything matches, then you may be probably more confident. This is how we do in clinical practice, isn't it? Right? So what point favoring is calcinosis, but anything else apart from chondrocalcinosis, or just that is the only reason? Once you read the chondrocalcinosis, it is pseudogout, like that only. Yes, Dr.
sir,
Jamal, any comment? Yeah, yeah, sorry, Dr. Asmat, sorry. Yes, Dr. Asmat.
in pseudogout is metabolic is it's a kind of metabolic disease. Here is calcium pyrophosphate dehydrate crystal.
Excellent. Excellent. Very excellent. So there are lots of point in gout. Usually small joints are involved. In pseudo gout, major long joints are or big joints are involved. Like in a gout, maybe great toe is involved, small or distal interphalangeal joints involved. In gout, hyperuricemia, either this different agent involved, right? It is in the main joint or large joint like knee joint. It is in knee joint. Usually, gout patient doesn't present with knee pain. Usually, they present with the toe pain. They present with the finger pain or so small joint, right? That is one more thing. Another thing is a chondrocalcinosis as well. That is also another thing. So let me go to the head-to-head comparison. Gout usually patient present 10 to over 40 years, and pseudo gout is elderly patient. So our patient is elderly patient, 70 years. So keep in mind, right? So age is important. Second thing is a site affected. So gout small joint, as I told you, and pseudo gout large joint, most commonly the knee. Our patient is also the knee is involved, right? Painful knee and swelling. So this is also matching. Second point. Third thing in the gout is clinical feature severe joint pain. Here also moderate to severe pain. It's same. Here soft tissue swelling in gout could be there. Here chondrocalcinosis or calcification of articular cartilage and meniscus. It is a pathognomonic. So chondrocalcinosis is also there in our scenario. Chondrocalcinosis. So age is favoring, large joint favoring, knee joint favoring, chondrocalcinosis favoring, everything favoring pseudo gout. And crystal formation is calcium pyrophosphate, which is in pseudo gout. Here uric acid. Gout is also known as hyperuricemia, right? Or excessive collection of this uric acid in the joint and tissue. And treatment is what in gout? Rest and NSAID, probably allopurinol, not at the time of pain, but for the prevention. And here the rest NSAID and joint aspiration as required to rule out the other different condition. So pseudo gout is a metabolic disease, as Dr. Asmat rightly said, where the calcium pyrophosphate dehydrate crystal, there is a urate or uric acid crystal there. So if you aspirate the joint in gout, you see the uric acid crystal. If you aspirate the joint in a pseudo gout, you will see what crystal? Pseudo calcium pyrophosphate dehydrate crystals. So both is the crystal is different. One is uric acid crystal, one is CPPD, that is calcium pyrophosphate dehydrate crystal. That's it. That's all for today. Thank you very much all for your kind attention. And I would be glad to have more questions before ending up my sessions today. I would be happy and glad if new students can give some interaction or feedback on my lectures today so I can improve my quality of lecture more. Anyone who is joined first time, I want to hear from you guys.
My name
Yes,
is
Dr.
Dr.
Negin,
Kiran.
yes, Dr. Kiran. So how is your experience of attending my first lecture? How is the quality and what you learned the new things or any
Um,
approach?
yes, I would like to talk about the approach. First
Okay,
is this is a very interesting and interactive mock test. I was
okay,
not actually expecting this. I was thinking of a very boring mock test in which only we uh, give the answer and move to the next question. But this is very, very interesting. And the thing which I like very much is the cartoon in which you do the post. Uh, what was that question? Post operative infections. I like it
Wonderful.
very much.
Yeah, wound water walking weird and
Yes,
this wound.
yes.
Wonderful, wonderful, wonderful,
Thank you
wonderful.
so very much.
No, no, just let me tell you, all the lectures are so interactive than this. So if you attend next lecture, you will forget this lecture because we work sincerely on this lecture. We are not just coming and presenting and go away. And I'm practicing for more than 20 plus years. So all my clinical experience, what I gathered, I'm trying to put into the lecture. You understand? So
Yes,
that
it should.
probably makes a
Yes.
difference. So that probably, and not me just only, all the coach, all the coach, all the
Hello,
coach.
sir.
Yes,
Hello, sir. I am Dr. Chinju, sir. I also want to say that this mock test initially I thought just coming up with MCQs and then moving to the next question after saying the answer or making some colors in the answer option, but you are completely with us helping out. And what I felt was that you come with questions, even if it's 15 questions or 20 questions, all those questions, the options or the questions which we suffer, which we struggle to come to an answer. That is very helpful for us, sir. Not the basic questions. The questions which you bring up are very, very indicative. You will be connecting us with those questions. That is very important for me, sir.
thank you very much
Felt
for
like
your
that.
kind feedback. Thank you, Chinchu, for your kind feedback. I would be glad to see you in the next lectures as well.
Okay,
Great,
fine, sir.
wonderful. Anyone else? Anyone
Sure.
else? First time. I mean,
Yes.
old player knows everything.
The efforts
But
it is incredible.
thank you very much. Anyone, Priya? How was your experience? I think you are joining first time by my experience.
Sir, I'm Yoga Priya, sir. Hello.
Sorry. Yes, Priya.
I'm Yoga Priya, sir. I attended your lectures already.
Oh, great, wonderful. I'm happy. So old people knows anyway, little quality anyway. Anyone else? Last, anyone? Any candidate? So they learned something new or which looks to be very fascinating for them. Any comment? Last comment? Then we'll end up.
Sir, this is Dr. Mahmoud Liman Hussain. So this is
Okay.
very, very nice lecture. Everything is clear. Thank you so much, sir. This is my first lecture. First I joined, and seriously, it's amazing. Thank you so much, sir. Hope we'll
Wonderful.
learn more from you.
Wonderful. Anytime you just get my number, keep in touch. Do let me
Sure.
know for
Thank
any
you, sir.
help. We are here to help you
Sure,
out.
sure, sir.
Anyone, someone was Dr. Jamal, your was also a first lecture, if I'm not wrong.
Yes, sir. This is my first lecture. Last time I did attend, but I couldn't complete it. Today I've complete a mock test, and sir, it is really agree with everybody. This is really very much interacting and very helping and supporting the way you explain, like a proper class teacher, like having a whiteboard and explaining everything. It make a good sense, and
Yeah,
we can retain it.
I'm a teacher. Thank you. Thank you very much. Yeah.
Yes,
Anyone
sir.
else?
And we are blessed to have you, sir. We are blessed to
No,
have you.
no, no. My pleasure, doctor. We all are a team. We are here to help each other. So don't worry. Everybody will pass the exam. Don't worry. Okay, fine. So thank you very much
Sure.
once again. Then keep in touch, right? Post in your group as well your feedback, your suggestions. I will be coming up with the next again the Master Blaster mock test. Meanwhile, stay tuned, stay connected. Thank you very much and enjoy your Sunday. Thank you.
Thank you, sir.
Bye bye. Take care.
अश्विनी ये तो है ना, ये गाजर वाजर थोड़ी